All right, so now let me go ahead and introduce our faculty. Dr. Praveen Kamani practices at Swedish Medical Group and is an investigator in the Prospect study. This is the largest therapeutic clinical trial ever conducted for essential tremor. He is board certified in neurology and did 2 fellowship programs, one in movement disorders at Stanford and the other in neuromuscular disorders at the University of Texas Southwestern. Dr. Kamani's peer-reviewed publications have focused on his multidisciplinary approach to movement disorders. And now, Dr. Kamani, to you.
Thank you, Debbie. Let me make sure I can share the screen and you guys can see what I can see. So thanks, Debbie. Thanks, Erday, and I thank you, associates at Cala Therapy, for inviting me today to talk about Cala Trio, a non-invasive neuromodulation therapy for symptomatic relief of essential tremor. And I'd also like to thank the audience members who have taken time out of their really busy day to join us. So thank you all. I think Debbie can tell you a lot more about how Cala Trio came into existence, but fundamentally, it was the brainchild of Dr. Kate Rosenbluth and engineers at Cala Health, and based on their knowledge of human anatomy, physiology, and preclinical trials, Cala Trio was designed for symptomatic relief of essential tremor. This is a paid program, and it is compensated, and it is sponsored by Cala Health. We will very briefly review essential tremor and its treatment before we jump right into Cala Trio therapy. Essential tremor is one of the most common neurological and the most common movement disorder affecting millions of people around the world and at least 7 million people in the United States. It is an action-oriented or action-based tremor, which makes it very challenging to perform even simple things like drinking coffee out of a cup without spilling, tying your shoelaces, maybe buttering a toast, etc. And not only does it interfere with day-to-day activities, it is quite embarrassing. And this particular study highlights the fact that mood disorders are 2 times as common in essential tremor as they are in age-matched healthy controls without tremor. Most people do provide a family history of another member with essential tremor, but that's not always the case. Sometimes a family history is not available, and sometimes, there are no other members affected by essential tremor. We do believe that it is an autosomal dominant disease with incomplete penetration, but a single gene has not been identified as causative of all essential tremor. In terms of treatment for essential tremor, what we have currently are these options that are not whole, they're not complete, and a lot of times we use multidisciplinary treatment for essential tremor because different options work for different people, and a priori it is difficult to determine which particular option is going to work for a particular person with essential tremor. Non-invasive medical options include those that are usually provided by occupational therapists, such as adaptive keyboards, eating utensils, weights, etc. We do not recommend self-medicating with alcohol, although if you see a large number of people with essential tremor over the years, you begin to identify how lots of families with essential tremor have become alcoholics because they haven't found a medication to treat their essential tremor, and alcohol is the only thing that works. Alcohol does not universally work for everyone with essential tremor either. In terms of common medications, we've got 2 that everybody recognizes, propranolol and primidone. One's a beta blocker, the other is a prebarbiturate. They are effective in about 50% of people, but as a tremor progresses and you increase the dose of the medications, compliance goes down because of potential side effects. So it's not a perfect therapy, and currently propranolol is the only FDA-approved medication for treatment of essential tremor. There are others with level B evidence, meaning evidence is not as robust, such as atenolol, gabapentin, topiramate, benzodiazepines we don't use. in essential tremor, commonly because they are addictive, and these medications are even less effective as a group for treatment of essential tremor. For people who are medication refractory, we have invasive neurosurgical options such as deep brain stimulation and thalamotomy. Deep brain stimulation has been around for at least 30 years, but it is associated with some serious complication risks, particularly if not performed at specialized centers that have a lot of experience in performing DBS. And there is a very sizable group of people who do not want invasive treatments for essential tremor. Thalamotomy, the modern era of thalamotomy is based on focused ultrasound treatment of essential tremor, unilateral treatment that's been available for about 3 years. It is also associated with a fairly large number of permanent side effects such as balance problems and sensory changes. So patient selection, candidate selection needs to be done very carefully. What else do we have? Well, enter Cala Trio. How does Cala Trio work? Before we talk about that, I'd like to talk about the individual components of Cala Trio, which are a stimulator, which is the brain of the device. It is individualized or calibrated to each patient's tremor. It is attached to the wrist through a replaceable band, which has the electrode or the stimulation, the portion that stimulates the wrist attached to it with surface electrodes. Both the band and the stimulator are docked in a charging base station, very easy to dock if you have essential tremor, which charges the stimulator, but also captures pre and post tremor kinematic data to be shared with Cala scientists. And we'll see a little bit more about this as we progress through our slides. Basically, the design of Cala Trio comes from preclinical studies and our knowledge of central tremor circuits. We do know that there are central and peripheral tremor circuits. In the central tremor circuit, the ventral intermedial thalamus, the VIM nucleus, has subpopulations of abnormally firing neurons, which we think are responsible for generating tremor. Neuromodulation of these neurons, either peripherally or centrally, disrupts this abnormally firing pattern, and that is the basis of design of Cala Trio. Asynchronous stimuli are applied to the median and radial nerves, which travel up the nerves through the cerebellum into the thalamus, and then desynchronize neurons that are firing off abnormally. And the stimulation is individualized to each person's tremor, so that is important to remember. It is customized a treatment. So that is what is thought to disrupt tremor circuit, and the name of that particular kind of stimulation is transcutaneous afferent pattern stimulation, or TAPS, and we will see a couple of randomized clinical trials that have demonstrated efficacy through TAPS or this particular modality. So on the screen, we have these two randomized clinical trials that utilize TAPS in single clinical settings in a sham trial to demonstrate efficacy of this kind of stimulation. On the left, we have a study that was performed with about 23 subjects and a control arm. These Archimedes spirals are part of the TETRAS, or the tremor rating scale, and this particular subset was studied pre and post stimulation. In the treatment arm, there is an observable significant improvement in the Archimedes spiral post stimulation versus the sham arm, in which there was really no improvement, and this is demonstrated through these bar graphs in which you see that there is no improvement in the tremor amplitude reduction in the sham arm. In another study which involved about 47 subjects and 30 controls, pre and post stimulation TETRAS scores were measured, as well as a subset of the Bain and Findlay activities of daily living score. And both the TETRAS and the activities of daily living showed significant improvement in the treatment arm compared to the sham arm. This led to the large-scale 3-month open-label study, or the PROSPECT study, to evaluate the safety and effectiveness of Cala Trio over a 3-month duration. Home use was also part of the study. So about 263 subjects at 26 sites were selected. The study designer, we will see a timeline of this, included 3 visits, a baseline visit, a 2-month visit, and the 3-month final visit. The TETRAS upper limb tremor subset score, as well as certain activities of daily living, were measured both pre and post stimulation in the office, as well as pre and post each home stimulation session. Kinematic data was also captured during this trial, which is one of the things that makes this trial fairly unique. The co-primary endpoints were the TETRAS subset score, as well as activities of daily living. The secondary endpoint was kinematic analysis of tremor amplitude at home over a 3-month period. The TETRAS stands for the Tremor Research Group Essential Tremor Rating Assessment Scale. It is one of the most common clinical scales we used in the clinic to assess tremor severity. Is considered to be the gold standard for tremor severity documentation, and also to look at the efficacy of medications. The ratings go from 0, which is normal, to 4, which is severe.
TETRAS is a validated comprehensive rating scale for essential tremor. Clinicians are provided a standardized 0 to 4 rating scale for 6 upper limb tasks.
So I was told earlier that some of these videos are not transmitting appropriately, and I'm not sure because on my screen they play beautifully, but if they're not playing well, I believe when this this recording is edited and put on the Cala Trio website, you will have an opportunity to access these videos again and see, if you're not able to visualize them appropriately at your end at this time.
They looked good.
Oh, good to know. Very good. Very good. Good. This is the timeline of the TETRAS, or the PROSPECT study. I'm sorry, visit 1, visit 2, visit 3, punctuated by home use of the Cala Trio therapy. At visit 1, we had numbers of scales, including TETRAS and activities of daily living, performed, as well as at visit 2 and visit 3. And at home, at least 2 sessions of 2 stimulation sessions with Cala Trio were required. The tremor was measured pre and post session by performing a specific tremor task, and we'll talk about that as we progress through the slides. As with all trials, we had inclusion and exclusion criteria. The minimum age of recruitment was 22 years. The minimum TETRAS score was greater than or equal to 2, and the activities of daily living greater than equal to 3 in any of the dominant hand tasks. The total TETRAS score in the dominant hand had to be greater than equal to 6, and the activities of living dominant hand score was greater than equal to 8 in all tasks. People had to be on a stable dose of tremor medications for at least 30 days prior to enrollment, if they were on tremor medications. Prior DBS, thalamotomy, epilepsy, any skin lesions around the dominant wrist, neuropathy such as carpal tunnel syndrome of the upper extremity, neurodegenerative disease other than essential tremor, for instance, Parkinson's disease, or the use of Botox for the treatment of hand tremor within 6 months of enrollment, pregnancy, or significant alcohol or caffeine intake within 8 hours before enrollment were disqualifying criteria. In terms of baseline clinical characteristics, I believe the population was generalizable to the general population. The average essential tremor duration was 25+ years. About 66% of patients were taking medications. Only a small subset were considering surgical options. There was a wide age range as well. And only a small percentage had botulinum toxin treatment before being enrolled. About a third, 37% were responsive to alcohol, and they were predominantly right-handed subjects. In terms of co-primary endpoints, we looked at TETRAS pre-stimulation at visit 1 versus TETRAS post-stimulation at the last visit. And there was a significant improvement in the TETRAS score from visit 1 to visit 3, but also in between visits. These were in-office visits. And activities of daily living also improved from pre-visit, visit 1 pre-stim to visit 3 post-stim. And activities of daily living improved by report during the clinic sessions as well. So to summarize it, there was a significant improvement in both co-primary endpoints in terms of TETRAS score, a subset of which was applicable to the upper limb, as well as activities of daily living. The majority of the improvement was seen in handwriting, pouring from a cup, or holding a spoon tasks. In terms of severity of TETRAS and Bain and Findlay activities of daily living, this is another way to visualize the co-primary endpoints. These two pie graphs show TETRAS scores pre-stim visit 1 versus post-stim visit 3. And these two pie graphs here show Bain and Findlay activities of daily living, visit 1 pre-stim and visit 3 post-stim. And the conclusion was about 62% of patients with severe or moderate TETRAS scores improved to mild or slight. Correspondingly, there was a functional improvement in 68% of patients who were severely affected in terms of activities of daily living to mildly affected. How about the safety of the study? These two columns here show percentage of subjects that reported adverse events, as well as the total number of events across all stimulation sessions. About 18% of the subjects reported adverse events, 5% related to skin irritation, about 4% to sores or lesions at the site of application. Important to remember that these device-related adverse events resolved on their own and didn't result in any dropouts. And there were others that are important to recognize: discomfort, electrical burns, which sounds very scary, but we didn't see any that required attention right away, and people went on with their treatment. Minor skin irritations, an electric shock sensation while using the device. It does feel a little bit like a shock. And then worsening of tremor in 1%, which was not clearly explicable. There are contraindications which actually parallel the exclusion criteria of the trial. The device should not be used in patients that are implanted with prior electrical medical device, such as pacemaker, defibrillator, or a deep brain stimulator, or by patients that have suspected or been diagnosed with epilepsy or another seizure disorder, by patients who are pregnant, and of course, it should not be applied to any area of the wrist which is swollen, infected, inflamed, or has any other kind of lesions. This is the before and after of a gentleman who has a fairly severe right hand tremor. When you look at it, it's classified as mild, but it is kind of functionally impairing. After treatment, there is a 25% improvement in the TETRAS score. Let's see if this video plays. So a woman who is trying to pour water into a cup, I see an obvious tremor at my end. And post-stimulation, she's able to pour water without spilling or without shaking. And this is about a 68% improvement in the TETRAS task when measured by the TETRAS rating scale. Now we come to some fun kinematics, and before I talk about it, I would like to thank one of the scientists at Cala, Dr. Apurva Rajagopal, who was very, very kind to walk me through these slides and help me understand the kinematics data and its application. So as a secondary endpoint, kinematic tremor data was captured by the device and it was sent to the scientists for an evaluation. On this slide, we see that the tremor power was plotted against the clinical TETRAS rating scale. The tremor power is a measurement of tremor severity, and there was a fairly high correlation between the objective kinematic data and the clinical TETRAS rating score. And here it is in terms of a column graph. A tremor power is plotted against session timing. On an average, there is a significant reduction in tremor power severity post-stimulation compared to pre-stimulation. And this actually is a culmination of 21,806, approximately 22,000 stimulation sessions. So that's a fairly large N, and these are all the stimulation sessions for all the subjects that were enrolled in the trial. So how is tremor power calculated? It is calculated through tremor acceleration. The stimulator, the Cala Trio stimulator, has accelerometers that measure tremor acceleration in 3 dimensions, X, Y, and Z. And that acceleration data is actually captured and it is converted to tremor power. This graph over here shows acceleration of the tremor in the Z-axis. This is the Y-axis and this is the X-axis. This raw data is collected and tremor power is calculated. In terms of tremor tasks, this is a distal postural hold task. The other task is a proximal postural hold task. The device is calibrated to treat the tremor which is most severe in either the distal or the proximal positions. And that hold is maintained for 20 seconds to capture kinematic data. This is the graph of one person's kinematic data plotted against the numbers of sessions. So let me just lead you through it. This is the tremor power, and these are the total numbers of sessions of this particular patient, patient 102-01. The black dots over here are tremor power pre-stimulation, and the teal dots over here are tremor power post-stimulation. And as you can see, on an average, the tremor power post-stimulation is much lower, meaning the tremor is less severe post-stimulation than pre-stimulation. When a ratio of the pre versus post is done, we see an at least 4-fold improvement in tremor power across all sessions. So if the average power pre-stim is 8 before the device is actually turned on, it is 2 after stimulation. So that is a significant reduction in tremor power or severity as demonstrated through this kinematic data. When you plot this data for all the subjects that were in the trial, each of these teal bars is a congregate of all the stimulation sessions for the patient. You see on an average, at least 50% of the patients over here at the 100 mark show an improvement ratio of 2 or greater, which means that a majority of the patients had at least a 50% reduction in tremor severity. A quarter of those patients actually had a 70% reduction in tremor severity post-stimulation. And a majority of the 92%, the majority of the patients had some amount of tremor power improvement post-stimulation. How does this data compare to real-world evidence? And this slide shows that on top, we have the prospect data, and here we have real world data of people who are using this particular device, and kinematic data is being captured. This is unpublished data. So we already discussed that up top over here in the prospect data, we had at least a 50% improvement and tremor scores in greater than 50% of the people. And that is emulated right here in the real world data, where 50% of the subjects that are continuing to use Cala Trio show at least a 1.7 time or a 50% improvement in tremor based on the improvement ratio. So this is good fidelity between the real life use of Cala Trio and the prospect study data. I think we are coming to the close of our presentation. So in summary, the key takeaways from this presentation are that the 3 clinical trials we talked about, the 2 randomized and the large prospect trial, demonstrate that TAPS therapy does provide significant benefit and a good safety profile over 3 months of home use. This particular response to therapy was reproduced across all clinician centers because it was a multi-center trial. The tremor reduction is comparable to first-line pharmacotherapies for propranolol or primidone. We talked about a 50% improvement, but without the side effect profile of these medications. And some patients had a greater than 55 to 90% improvement in tremor compared to surgical outcomes, which are deep brain stimulation outcomes. But of course, this treatment is reversible and does not have the risk of permanent side effects associated with brain surgery. And the kinematic data, I think, are really exciting because they really pave the path for capturing objective tremor data at home when patients are, not able to come to clinic, or if we really want to know how they're doing at home. And this can allow us to see if the device is effective over time in a longitudinal fashion. I'm sure we all want to know how to get this device for our patients. And this slide, just shows a little snippet of that prescription form that you need to order the device. I believe you can call this 1833 number at the bottom or contact Debbie over here who can get you the prescription forms. If you find candidates who are patients are good candidates for this treatment, you'd have to identify the hand which is more affected by the tremor and also determine the position in which the tremor is worse, either a distal hold or a postural hold. And it's also important to determine the wrist size of the wrist appropriately, because you want the electrodes, the stimulating electrodes, to have a good contact with the median and radial nerves. And I don't want to get a false sort of a negative if the electrodes are not in touch with the nerves. So sizing the wrist to get the appropriate band is important. And I think with that, I thank you very much for your attention. And I'm happy to field a few questions. I think I went through this pretty fast. I hope it was comprehensible. So we are at about 28 or 29 minutes. And what I'm going to do, if okay with Debbie, is stop sharing the screen at this time. And if Debbie or Eriday want to put up another slide for your information on the website, etc., they can do it at this time.
So the first thing I wanted to do is jump back into poll questions. And given that we are now in a post-COVID world, I wanted to ask for everyone who's on the call right now, if they could just answer, before the pandemic, were you regularly conducting telehealth appointments, 1 to 5 a month? If you could just go ahead and answer that question. And while we answer that question, I'd like Dr. Kamani to speak a little bit to his experience most recently doing telehealth appointments. How's that been for you in your practice?
Yeah, happy to talk about that. Well, we were not doing any telehealth before the pandemic. So this pandemic, as your audience will tell you, really ushered us, actually projected us into the world of telehealth and telemedicine. And thus far, it's going really well for my patients, provided they have a good Wi-Fi connection, because I tell them, listen, I want to see your tremor, not the tremor of your video camera or your iPhone, etc. So it's very important that they have a stable connection. And if they do, I really can perform a good tremor exam online. And I've been doing a lot of other telemedicine for other disorders such as Parkinson's disease, etc. So thus far, I would say it's been a very positive experience for me.
Great. So if we could show the poll results for the first poll question. And so a lot of you were not doing telehealth before this. So the second question I would like to ask the team here, the group, is today, are you conducting telehealth appointments for your existing patients only, for existing and new patients? Are you just getting started and you're not yet doing it or not interested? And while we go ahead and answer this question, I will go ahead and ask Dr. Salima Brillman is also on the line today, and she has been prescribing Cala Trio through telemedicine since August 2019, which was pre-pandemic. So Dr. Brillman, can you share a few little tips about telehealth appointments for new patients that you see and that are requesting Cala Trio therapy, and also just to mention how long it takes for you to do those appointments?
Yeah, sure. So it's very streamlined. The appointments are scheduled through Cala, and it's on my appointment via Zoom, my appointment calendar, and the patients as well. And we get together and have the appointment depending on the person and how much, information they want to share with me. It takes about 15 minutes or so. And I'll do an examination with them via telemedicine and have them do a spiral, etc. They have a questionnaire that they are to answer some questions prior, and this is uploaded for me. And then that is used in I view that prior, and then if I think that they are that they would benefit from the Cala Trio, then I go ahead and submit that prescription to them, for them rather.
Great, thank you. We're starting to get some really good questions in, so let's go ahead and show the poll answers, and then I will start to organize the questions and fire them off to Dr. Kamani. And there we go. So we are seeing an increase, almost an exact amount of people are increasing now, but relative. So this is great to see. And I know that patients are definitely interested in going to their own physicians to get Cala Trio prescribed. So the first question I want to ask from Dr. Goitz is, can you treat both hands or the dominant most severe?
Okay, so I can answer based on my experience and the trial. The trial used the dominant most severe, and in my experience, I've been using the dominant most severe, but according to what I just found out, that you can order bands for either the right arm or the left arm, both. But majority of the time, it is a unilateral therapy for the most severely affected arm. And the patients actually guide us on that. They tell us, well, I use my right hand, I'm right-handed, or, although I'm right-handed, my tremor is not as severe in the right hand, and it's the left-hand tremor that bothers me, so you can actually get a band for the left hand. So that's a conversation I have with my patients. But I'm going to ask Debbie to also chime in and tell us about the dual bands, the right and left, if you can, Debbie, please.
Sure. So the bands, as well as the device, are both set for being right-handed or left-handed. And so that's why you have to make a decision about which hand you're doing. Now, if you have a patient that needs to have both hands treated, then you write a prescription for each hand separately, and then our customer success team will work through that issue with the patient. So that is possible to do. Dr. Kamani, the next question that we have is that several people have asked how soon after stimulation, or how long does the benefit last once the person's completed their stimulation? According to the prospect data, what did we see?
According to the prospect data, reportedly about 96 minutes, is slightly greater than an hour and a half. And while you were talking, Debbie, we had lots of questions in the chat box as well that I was answering, so you could take a look at those as well. And sorry, my typewriter was going, I had to mute myself. But it's now there, in my personal experience, I've had 2 or 3 patients who have stimulated themselves in more than 2 sessions, and they have derived benefit beyond the 1.5 hours. So the numbers of stimulation in the trial were 2, but we were talking about this right before the session in terms of what is the prescribing information, and Eridai very graciously told us what's in the prescription or the instruction booklet. It's at least 2 sessions. So there's no limitation on the number of times you could stimulate to get tremor benefit, as long as the stimulator is appropriately charged.
Great. So here is another question. In the age of COVID, patients can't size, the physician is not going to be able to size the patient with their band. So the question is, can they size themselves? And Dr. Kamani, if you could answer how that would work.
Okay, right. So this is interesting. When I was talking to a prior Cala associate, we had this issue about sizing and how do you size a patient. In the clinic, we have sizing bands. So I can very easily size a wrist. In the past, I've had the patient actually directly communicate with Cala Health, and the bands have been sent to the patient so the patients can size themselves. And that's what I've been doing, and it's been working for my patients. But if there is a better way to do this, Debbie, please educate all of us.
Yes, actually, I was talking to our customer success team yesterday, and they were telling me some of the clever ways that they have people measure. So the first thing they might do is ask the patient if they have their own measuring tape at home. And on the prescription form, there is a ruler that can be used. So let's say you didn't have a measuring tape, but you just had a piece of flexible string or a shoelace. The person could put the shoelace around their wrist and then mark the sides and then place it onto a hard ruler, or even on the side of the prescription form, and that would tell them what their size is. And they could report that information to you during a telehealth appointment. So that's a couple of little hacks that we use. And like I said, the Cala Health customer success team has been very successful. They give the patient plenty of time to go find some sort of a measuring device. So if you don't have time during your prescribing appointment, you're more than welcome to have the Cala Health customer success team take care of the sizing issue for you. So that's how we handle that. So the next question I wanted to make sure that we covered is, so Dr. Grill asks, so this would be used prior to an activity to suppress the tremor. And one of the questions he also asked was, and that I answered, was that the tremor effect in the prospect study lasted about 97 minutes. So Dr. Kamani, let's talk a little bit more about why do you use this right before the tremor task, or not the tremor task, but the task that you want the tremor to be suppressed for? So how often did that come up? Like, what do you say to your patients?
Well, I explained the rationale for the post-stimulation improvement, and I was answering Dr. Grill's question in the chat box as well, and I will reiterate it that it's an on-demand therapy, so therefore, if you do know that you're going to be performing a task such as writing postcards or writing letters, etc., it's Christmas time, you want the tremor to be suppressed, you want to stimulate yourself for at least 40 minutes. before that task, the effect is immediate. It may last 96 minutes, it may last more, it may last less, because that's the average amount of time. But there is no limitation to the numbers of times you can stimulate, except that you would have to stimulate for 40 minutes for the tremor effects to be substantial, or to basically recapitulate what we saw in the Prospect trial, what was reported. But I was also told by Cala, and I think it was yourself and Dr. Rajagopal, that other studies are being done at Cala to determine optimum numbers of stimulation, optimum time of improvement based upon the kinematic data, which I think is one of the biggest advantages of this particular device, is that you are able to longitudinally monitor and through an iterative process come back and finesse the numbers of stimulation and maybe educate us more. I don't believe, as someone asked me, if there was going to be another blinded study, not to the best of my knowledge, but I was told by Cala that as we discover more and more about optimization of the device, that clinicians would be informed about this as time goes on. But can you speak a little bit more to that, please?
Sure. So the reason why the Prospect trial did not have a sham arm, unlike the original 2 feasibility trials that we did, is because you know that you're being stimmed. So it feels a little bit like when your hand falls asleep. So once you get a sense of what that feels like, it would be hard to pretend that that's working or not. So if it wasn't stimming, your hand wouldn't fall asleep or feel that tingling sensation. So it's a little bit of a challenge to, once someone tries it the first time, it's really easy for us to create a sham component. The second time, it's a little harder. So because this is longitudinal over 3 months, it makes sense that that the Prospect study did not have a sham component to it. So I hope that answers that question. And as far as what Dr. Kamani is talking about relative to additional studies, we are looking at real world evidence, and we're looking at how, if there's any predictive analytics that we can see from our Prospect data. There was another question that asked, when did we do the Tetris and ADL ratings in the clinic? And it was immediately following those 40-minute treatment sessions. So we're looking at all this data. And like he said, the fact that we're recording it all and we're able to see things before and after each treatment session, the kinematic data and other questionnaire data that we ask may start to show us and point us in a direction that we'll be able to report in future studies and publications. So Dr. Kamani, Dr. Grill also asked, could you stimulate at different frequencies, one of which you think will not be effective? And I think that's a device question. Sorry, Dr. Kamani. I think that's a device iteration question. And we are looking at other ways to program the device that might potentially in the future could facilitate it. Dr. Kamani, go ahead, and what answers do you have for that?
Yes. Can you hear me now? Am I unmuted? Okay, just want to make sure. First, I want to go to the sham thing. As we were reviewing the data, and I was again talking to Dr. Rajagopal, and I asked her the same question, the sham question. She astutely pointed out that although there was not a sham trial, she pointed out the correlation between the kinematic data and the clinical Tetris rating scale, and the kinematic data was subjective. The clinical Tetris rating scale, kinematic data scale was objective, Tetris rating scale is subjective. So I think that sort of overcomes this issue of sham, that there was a very good correlation between the objective and the subjective, which is now the gold standard. So I think that's an important point to remember, although there was no sham study. As far as stimulating at another frequency, I don't think we have the ability to do that now, and it is the neurophysiology of stimulating at the patient's own frequency to disrupt the firing of the thalamic neurons, which leads us to stimulate at the patient's frequency. And I don't know if I talked about the calibration bit, in which the device is calibrated by the patient holding their arm in the position of maximum tremor severity, which allows the device to set the frequency of stimulation. And I think if that answer is too obvious, I'm sorry, but that's the only thing I know about the device being stimulated at that frequency. I don't think it is like deep brain stimulation where you change the frequency of the central stimulation. So that's my knowledge about frequency of stimulation at the.
Sure. So I'd like to go on to another question from Dr. Kremens, and he was asking, mentioning that in his academic setting, Cala couldn't help schedule telemedicine appointments. And so I wanted to assure you that part of the reason that we are recording today's session is so that we can capture some of these little nuggets about doing telemedicine. We are putting together a telemedicine kit of materials for you to use, so that as you begin to do telemedicine appointments in your clinic at your university, that it becomes easy for you to help a patient get through a Cala Trio prescribing session. Not difficult, certainly, and certainly something that we understand that you will need some help with. So we're putting those materials together right now. You should see them soon, and I'll certainly be sending emails out. So. One other question from Dr. Grill was insurance. And I know Dr. Kamani answered back correctly that we have an application for the Cala Trio device to CMS right now, and we don't have coverage. It is eligible for flexible spending and healthcare savings accounts. It is an eligible qualified expense under those circumstances. And the question about, can patients try it before purchase? So what happens is that a patient has a 60-day period of time when they're trying the device and they're optimizing their therapy to see if it works for them. And if it does not work, we do have a money-back guarantee. There's only a $99 fee for returning the device. So there is a way for a patient to try this, because we do know that not every patient is going to respond in the same way. And we want to make sure that we get the patients who are responding onto the therapy as efficiently as possible. So we give them a nice broad period of time for them to test the device to make sure it works for them. Dr. Kwani, do you have any other thoughts about that, about the trial period, or anything from your experience?
Yes, quickly, Dr. Grill asked about the cost. When I was communicating with one of your associates, Debbie, a table was provided to me on various cost structures. I don't have it memorized. There is an upfront cost, there is an installment cost, there is a licensure fee. So I think there are a few components of the cost structure. Where can Dr. Grill and other clinicians go to determine what these cost structures are so they can counsel their patients and inform them appropriately? And then I'll come back and answer the other questions.
Okay, great. So the MSRP for the device is $3,200, and there's a band subscription that goes with that, and that's on top of it. And then based on qualifying criteria, the patients may be eligible for different packages. So you can either buy the device and have a band subscription, or you can finance the device and have the band subscription. And the best way to handle that is honestly to call our customer success team, and they can walk you through some of the details about that. And they usually, once you've sent in the prescription, they will work directly with the patient on that. And so it's really something that you don't necessarily need to worry about as a clinician. If the patient's interested in trying the device, usually the patient and Cala will find a way to work it out so that they can try it and see if it works for them. So I have some questions in the answer area, and the first question is the physician the one who orders and fits the patient? And I would say that the clinician who has the essential tremor patient should be Yes, so the clinician is the person who can fit the device through a telehealth appointment or in person, like we've just discussed, and they fill out the prescription form and sign it. So it is a prescription device, so that prescription form needs to be completed. And the three things we need are the hand, left or right, the tremor task, and again, the measurement of the wrist. Again, the measurement of the wrist can be punted over to our customer success team. They can take care of that. So the physician is the one who signs the prescription order. And in some states, other allied health professionals, advanced practitioners, have prescribing authority. So if you are in that circumstance, then you would know whether you can prescribe this device. There's another question here about the doctor referring to patients to occupational therapists and what is their role in the treatment. And I think that, Dr. Kamani, do you have any thoughts about where an occupational therapist fits into this, what their role fits into this?
Oops, sorry, did I do something wrong? I apologize.
No, you're good.
Okay, I'm back. Yes, one of the things, the key term is multidisciplinary. So this is important to remember that Cala therapy is not an all or none. There were 75% of people who were taking essential tremor medications as well. So you don't necessarily have to fail your ET medication to go on to Cala therapy. In my clinic, I use the occupational therapist. I use medications as well as Cala therapy to provide the best treatment I can for the patient, because we've realized that a multi-pronged treatment for essential tremor, which now we recognize as a syndrome, not a disease, very heterogeneous, works really well, except for DBS, because once you've had DBS, you cannot have a Cala therapy. So I try to optimize it all, not unlike managing Parkinson's disease with multiple medications and modalities. Where the OT comes in is sometimes people with essential tremor can also have a mild dystonic component, and I believe that the OT can help with that. If the patient's tremor improves with writing, for instance, but not with eating, and that's possible, then the OT can help with proper utensils for eating. So again, a running dialogue with the patient is important to understand what their needs are, and therefore you can make an occupational therapy referral accordingly. I do not think as a standard, I do occupational therapy for everyone with essential tremor. It just depends on what my conversation is, and I customize treatment to that individual, not unlike you're customizing Cala therapy to the patient's tremor. The other thing I want to say really quickly is this post-purchase help from Cala. And initially when I prescribed it, the patient made an appointment to talk to me. I didn't know that she would bring her entire package to the clinic and ask me to show her how to use it. I could have, but that caught me off guard. The patient didn't realize that she could call Cala therapy, and there are people at the other end who could walk her on how to use it, how to calibrate it. And once she realized that, and she did that right in the clinic, she went online. It was very easy. So before I get distracted, I'm just going to request Debbie or Erday to explain your customer service bit after patients make the purchase and what kind of help they have to learn how to use the device.
You got it. So yes, as Dr. Kamani has said, our customer success team is trained to train your patients on the minute that their box arrives, they can watch videos that we have on a website called my.calatrio.com. They can read the materials that are provided in their box. They can call or have an appointment scheduled with our customer success team, and our customer success team will walk them through every step of the calibration, all the way through to changing the bands. And there was a question from Dr. Goitz about band changing, and the answer is yes. The bands are changed every 3 months, and it is because there are 2 electrodes. Thank you. There are 2 electrodes in the device on the band on the inside. And in order for those 2 electrodes to properly work, they need to stay clean and they need to stay dry. And after regular use over 3 months, those electrodes might become deteriorated. So I'm going to put it up to my camera here on the screen. There are the 2 electrodes. And this is directly onto your skin, onto the patient's skin. And so just over time, it can get dirty, and the effectiveness of the treatment could be impacted if the electrodes are not at their optimum usage. So that's why changing the bands every 3 months is critical to maintaining efficacy of therapy. So I hope that answers your question. And we have just one last minute here. And I want to double check that there are, I think that we've answered all of the questions. And hopefully, and I do want to let you know that there are several folks on the line today who can do an in-service, a virtual in-service, of course, everything's virtual these days. And so the reason why we have the information posted up here is that you can sign up for a virtual in-service. You can raise your hand, you can send us an email, and we will assign you to someone to walk you through more data questions, more questions about the device, more questions about the science. We have lots of ways to answer all your questions, and we couldn't do it all today and crammed into an hour, but I'm really thrilled about the questions that came in. These are common things that we get asked, and we're really, really excited to see the Cala Trio be used in this critical time, now that patients who have essential tremor need to figure out how to isolate and do social distancing and take care of themselves in a safe way. I always think of the patient that is trying to cook for themselves. And if you have an essential tremor and it's when you're trying to chop, good grief, I would not want them to slice their hand open and then have to go to an emergency room. So for me, when I think about the need for the essential tremor patient for the Cala Trio device, now more than ever, and the fact that we can help these patients through telehealth appointments and very virtual prescribing and delivery systems, I think we're really happy to be in a position to really make patients' lives better. So with that, I will close this session, and thank you, Dr. Kamani, so much for your time today and for all the lovely questions. Also, Dr. Brillman, thank you for hitting on the telehealth, because it was really nice to hear another perspective on how that's working. And thank you so much for your time today, everybody. I hope you have a very healthy and safe upcoming holiday weekend. As we like to say, wash hands. Good night, everybody.